You are a surgeon. You are also something else. Most days you forget which one you are first. You are 38 years old, 11 years at Mercy General Hospital in Columbus, Ohio, board certified in cardiothoracic surgery. 214 successful procedures cataloged in a file nobody reads twice. A photograph on the fourth floor department wall between Dr. Robert Finch and Dr. Patricia Hale. Your smile in that photograph is real. You remember the day it was taken. You were proud. That version of you still exists. He shows up every morning at 5:47 a.m., scrubs in, saves the people he is paid to save, goes home, feeds the dog, calls his mother on Sundays. The other version started 3 years ago in a supply room at the end of the East Wing hallway that nobody uses after 9 p.m. It did not begin with evil. That is the important thing to understand. It began with a man named James Calloway, 54 years old, stage 4 pancreatic cancer, a prognosis of 11 weeks, a wife named Donna who held his hand every visiting hour in room 214, like she was the only thing keeping him from going under. James Calloway was going to die. The medicine available to him had already done everything medicine could do, which was nothing, and you had been reading quietly, carefully in the hours between surgeries and sleep about a compound that had shown results in 3 unpublished trials in Germany, not approved, not legal for administration in any American hospital, not even close to it. But James Calloway had 11 weeks. You made a decision. You told yourself it was compassion. Maybe it was. You administered the compound during a routine procedure, disguised inside a post-operative cocktail documented as something generic and forgettable. You watched. James Calloway lived 14 months. That is the number that broke you open, not 11 weeks. 14 months. Donna Calloway sent you a Christmas card that year. A photograph of the two of them at their daughter's wedding. James in a gray suit, thin but standing, smiling like a man who knows precisely what he's been handed and intends to hold it as long as his hands allow. You taped it to the inside of your locker. You still look at it. But the thing that happened next is the thing you don't talk about. Because James Calloway's 14 months did not feel like an ending. It felt like the first sentence of a question only you were positioned to finish. The data existed, the mechanism was partially mapped, the results were real and reproducible and sitting in a notebook that had no business existing inside a hospital with your name on the wall. You needed another patient. This is where the version of you that teaches second-year residents and calls his mother on Sundays starts to become difficult to locate. You do not select randomly. That is the first rule you establish. The way someone preparing to do something wrong builds a perimeter of logic around it to make it feel like policy. You select terminal patients only. People the system has already signed off on. People for whom every established option has been exhausted and documented and filed. People for whom your involvement is not a subtraction from their odds. It is an addition. You tell yourself this enough times that it stops sounding like telling. The second patient is Raymond Stokes, 61, inoperable glioblastoma, 4 months to live, a daughter named Alicia who drives in from Cincinnati every weekend and pretends not to cry in the hallway after visits. You administer a modified version of the compound, refined now, the dosage recalibrated based on what James Calloway's blood work taught you in the months after his procedure. You log it as a standard post-operative intervention with a name generic enough to disappear into a chart. Raymond Stokes lives 6 months, 2 beyond his projection. Alicia brings you a bottle of scotch when he passes. She says you were the best part of his last year. She doesn't know why that's true. She never will. You accept the bottle and say something quiet and true about what a remarkable man her father was, and because he was, and the two things, what you know and what she knows, exist in the same room without touching. You drink the scotch in the supply room at 11 p.m. on a Tuesday alone. You write Raymond Stokes' name in the notebook, and by the end of year 2, the notebook has 7 names. You become precise. This is what 11 years of surgery trains you for without knowing it. Performance under conditions that would unravel other people. Your hands do not shake. Your voice does not change register. You operate in the morning, document in the evening, and the two halves of the day exist in rooms so separate inside you that crossing between them requires almost no effort anymore. The lack of effort is something you don't examine at. Dr. Robert Finch, your closest colleague, 15 years in the field, the kind of surgeon people fly across states to have standing over them, begins to notice something, not the experiments, but you. The way you've gone quieter at lunch, the way you sometimes pause in the corridor after leaving a patient's room, standing still in a way that looks like thought but is actually something you don't have a clean word for. He asks you one afternoon in the break room whether you're sleeping. You say yes. He nods. He doesn't believe you. He doesn't push. Robert Finch is a man who extends trust to people he respects, and he respects you more than almost anyone in that building. That trust is the only structural reason this has lasted 2 years and 7 patients. You understand that clearly. You feel something about understanding it clearly. You don't look at that feeling directly. The close call comes in November. A nurse named Linda Hayes, pediatric floor, never worked your wing, covers a night shift due to a staffing shortage. She is in the East Wing hallway at 10:15 p.m. looking for a medication cart logged in the wrong location by the previous shift. She sees the light under the supply room door. She knocks. You open it. You are standing in front of a folding table with 2 labeled vials, a laptop, and a legal pad covered in handwriting that would take 4 seconds to read and 40 years to explain. She looks at you. You look at her. You say calmly, the way surgeons are trained to be calm in moments that require it, I'm reviewing compound interactions for tomorrow's procedure. The attending lounge was full. She says, oh, okay. She finds her cart 17 feet further down the hallway and doesn't come back. She never files a report, but she looks at you differently in the weeks that follow, not with suspicion exactly, with something quieter, something you cannot categorize and therefore cannot neutralize. You change 3 elements of your documentation process. You stop working in the supply room past 9:30. You are more careful. The word careful used to mean something different to you. What nobody tells you about living 2 lives inside one body is that the division does not hold permanently. You built a wall, and for 2 years that wall was load-bearing. Now it has fractures you can feel but not see. You save a woman named Carol Briggs, 42, routine bypass, clean outcome, home in 4 days. She sends a card that says you gave her life back. You read it in the parking garage on a Thursday evening and feel nothing. And the nothing is worse than grief would be, worse than guilt, because you remember feeling everything in this work. That feeling was the reason you walked into a lecture hall in Cincinnati at 22 years old and decided this was the thing you were going to give your life to. A professor told your class that surgery was the closest science had ever come to grace. You believed him then without reservation. You are not sure what you believe now. You are sure of the data. That is what remains when the other things thin out. The data is real and it doesn't negotiate. 3 of your 7 patients outlived their projections by a combined 26 months, 26 months that no approved treatment, no funded clinical trial, no specialist reachable by referral could have produced. There are people who attended weddings because of what you did in that supply room. There are also people who died as variables in a study that will never be published. And the distance between those 2 sentences is where you live now every day without a compass. Then there is Thomas Wren. Thomas Wren is 58. Liver failure, cascading secondary complications, transferred to comfort care. He should not be a candidate. He is too compromised, the margins too unpredictable, the risk profile outside even the private parameters you've established for yourself over 2 years of careful selection. You administer the compound anyway, because the data from a patient at his level of deterioration is the one gap in the notebook. because you have moved past asking whether this works. You are asking how it works and under what conditions it fails and where the ceiling is, and you need the full range of the data set to know. Thomas Wren survives. His recovery is slow and medically strange across 3 separate markers. Dr. Finch consults on his case and uses the word remarkable twice in a tone that is shaped like a statement but functions like a question. 3 months later, Thomas Wren is well enough to sit in the chair by the window in his room. He asks to speak with you privately. You sit across from him. The afternoon light comes in flat and pale through the blinds. He says, "I know you did something to me that you weren't supposed to do." You start to speak. He says, "I'm not angry." The room goes very quiet. He says, "I just need to know if it's going to keep working." You don't answer, not because you don't have one, because the answer is the most dangerous sentence you've ever assembled, and you haven't yet decided whether releasing it into the world is a medical decision or something else entirely. Something for which medicine does not have a category. Thomas Wren watches you with the patience of a man who has sat across from death and found it smaller than he expected. He is not afraid of you. He is not afraid of anything you could say. That is the most unsettling thing you have encountered in 3 years. More unsettling than Linda Hayes in the hallway. More unsettling than The Notebook. More unsettling than Donna Calloway's Christmas card, which you still look at. A man who needs nothing from you is a man you cannot manage. You are still operating. Room 4 is prepped. A man named Gary Mitchell, 49, a procedure with a clean outcome written into it if the surgeon is present. You are always present in this room. It is the one environment where the two halves of you reach a complete agreement. Both of them want the same thing for Gary Mitchell, and they execute it together without friction. Your hands are gloved. The team is assembled. Dr. Finch is across the table. He says, "Good morning." You say, "Good morning." The overhead lights come on. The room goes quiet in the particular way it does in the seconds before the first incision. That held breath stillness where every person in the room is running the same silent calculation, ready, focused, committed. You are 38 years old, 11 years at Mercy General, 221 procedures, 7 names in a notebook in the back of a locked drawer. One patient who knows. One question Thomas Wren asked that you have not answered. You make the first incision. You are a surgeon. You are also something else. Most days you forget which one you are first. Today is not one of those days.